Welcome back, Sports Medicine Project people. Hope you're all doing incredibly well. Kelly, how are you doing?
I am good. How are you?
Good, doing really well. How's the day been?
Today's been good. Did a long run this morning. I was so excited to do a long run, but far out my legs are sore. I feel like I haven't long run in 3 weeks and I feel fatigued.
Yeah,
today.
we're going to get to that in your high today. You are back, wouldn't say full volume. What percentage do you think you're back running?
I did 50 kilometres this week and I was doing about 60, so I don't know percentage-wise.
Yeah, whatever that is. I don't want to even try and work that out and get it wrong
5%.
out in the open. But so we've got some exciting news before we get into a couple of things. We're going to talk about Dr. Stephen Kent's podcast, which is this episode is going to be about part 1, talking about syndesmosis injuries. However, got some very exciting news. I don't know how exciting it is. It's somewhat exciting. We've been at it for like a couple of weeks now and we've just been constantly arguing. Yeah. So we're rebranding more so the colours. We're not changing the name or anything. It's still Sports Medicine Project, but changing the colours, adding a little note to the end. So we've been thinking about, what do we want from this podcast? What do we want it to be about? Now, yeah, what do you want it to be about, Kelly? What do you think when you think about this podcast?
You've just thrown me under the bus. On the spot.
On the spot, yeah. Well, we talked about, with purely maybe focusing on something like running because we're really interested about that, or then focusing more on something sporting related. And then, the idea of creating it was for people, we just want people to have a better understanding of topics that sit under the sports medicine umbrella. Just happens to be that we like running, so we talk about running a lot. But it encompasses a lot of things. So running, training, concepts to think about clinically, and my bias and working in things at the university and having a passion for education, I definitely know that my bias leans a little bit more towards younger graduates and just people that really allied health, I guess. And I like providing and I guess synthesizing information for them to then think about it and go and use clinically. So that's pretty exciting, I think. So what's going to be our tagline, Kelly? Take it away. What is it?
It is a better understanding. However, if anyone has a different word for understanding, let us know.
Synonym.
Synonym.
What did you say? A cinnamon.
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 Medigen. I don't know if I like the word understanding. I like a better understanding because I feel like that does encompass all things. I just don't know if I like that word. I just don't feel like it flows,
Yeah. Well, I've just announced that we're changing it.
Yeah.
To that, but we're not now. We've got to find a better word first.
Oh, I thought it was still a little bit like in the draft zone.
Yeah, I thought we had the picture ready. So take back everything that I've just said. We're not rebranding at all until we find a better word for understanding.
Well, maybe. Well, I'll just check the thesaurus later.
Yeah, but that's the idea of the podcast. So if you are listening to this and you've gotten this far in, we want these podcasts to just help people have a better understanding about lots and lots of different topics. Now, we're definitely not saying that we are the almighty and all-knowing on these topics, but we talk to a lot of people who we think are pretty knowledgeable on certain topics, and we also like to give some of our clinical experience and things like that. So, yeah, that's what we wanted to say in the intro. Just like, do you have anything to add into that?
Well, that's why we started the podcast, wasn't it? Because we just like our conversations on a regular basis are just us going back and forth about injuries or running or training or something like that, and it's all
what
just
to do
us
sort of
having conflicting opinions. That the more times you have these conversations, the better of an understanding around that topic you may have.
Yeah, and also some of the things that just happen clinically. Like, I know there's a ton of students that listen to this that I teach at the university, and I know there's tons of podiatrists and physios and chiros that listen to this as well. What I like about this is, in our dialogue is when we talk about those situations that, you typically don't hear from other podcasts, in the sense of, you might have someone with a PhD talking about running injuries, which is bloody awesome, but having someone have some dialogue talking about how do you actually see a runner in the clinic and all the different concepts to think about, because the research translation, that's difficult, and it's always been something that we all struggle with, but that's what I really like about our podcast. So that's what I want, to be one of the goals.
The other thing that I like about our podcast is when you listen to other podcasts and people are interviewing guests, then you often are taking like everything that they say as gospel because they're obviously the more knowledgeable person. Whereas I feel quite comfortable having a bit of a debate with you and letting people know that it's not always black and white and there's not always one way to do things. You can have multiple successful outcomes with different treatment options or management plans. And I like that we can be open about having those conversations together.
Yeah, and we are always going to be wrong. And I think no matter if you're not always. No matter if you're in your first year or you're 20 years down the track, you've really got to get comfortable with either not knowing or getting it wrong. One thing over the last couple of weeks, I think it was probably the last month, that I did, because I'm happy to be openly wrong compared to when I very first started out. I probably was, I guess, insecure as a clinician and also a little bit too confident. You come out of university thinking you do know it all. But
Dunning-Kruger effect.
Yeah. I booked a patient of mine in with a colleague that after a couple of sessions, because we weren't getting an improvement, and was completely transparent with the patient, said I would just love to have another set of eyes on this. Colleague would be more than happy to see you. I've explained everything. They were more than happy, and I think that can be a little bit scary sometimes, like, I don't want the patient to think I don't know anything. What's my colleague going to think? That kind of thing. But patient saw this other person and said, yep, that's fine. I think continue down that track. Patient come back and saw me, and then we actually ended up getting a pretty big win after a couple more sessions. So that's something that I've gotten from this podcast, being and doing the podcast and happily being openly wrong and not having that insecurity, which we always talk about, which is so important.
Yeah, we often, in the clinic at our work, we often... like I'll be treating a patient and I'll go out and be like, hey Joe, come in here, do you want to have, can you have another look at this? I just want another set of eyes on it. Or Dave, same thing to Dave, and anyone in the clinic who's around, particularly if we're suspecting an ACL or a bigger injury, it's nice to have another clinician assess it as well.
Yeah, this is today's topic, and I'm so excited. I'm always excited for people to listen, but I'm so keen for podiatrists to listen to this one because, we typically, because we're more, I guess we see more chronic conditions, and more so we're not usually managing, the acute ankle or the acute syndesmotic injury, which is what we're talking about today. If that came into my clinic, I would be so confident now, not probably treating it in the sense of just sending it to someone else like yourself or a physio that just sees that a lot more. Whereas I think when I was younger, I would have thought that I could have, been everything to everyone, which is awesome. Yeah, good. So the podcast is awesome is basically what we're saying.
A little bit of a plug.
Yeah, I don't know. I don't want to be like ego, but I really, I think, and I thought about this that's one on my training for this marathon, because I'm doing a lot of longer, easy runs, got a lot of time to think. And I think if nobody listened to this, we would still do it. When I say I mean the Instagram, but I would still do this podcast with you because I think it makes myself, and hopefully you think it makes yourself, a better clinician. But it really is just, I really do, I'm passionate about this stuff. It's really, really good.
I look forward to the conversation, the podcasting.
Yeah, as long as we're not doing it after 4 p.m, because then you're in the hole, in the K-hole. Yeah. All right, so what are we talking about on today's episode? Kelly, you take over. I'm not knowledgeable on this topic at all. We're talking about syndesmotic injuries, but...
with Dr. Stephen Kent. So Stephen Kent is a foot and ankle orthopedic surgeon in Newcastle. This is the second time we've had him on, and we talk about this in the podcast. He's our first actual guest.
Yes.
That has come on
twice.
Yeah.
Which was
very
awesome.
Close to 4 o'clock.
Yeah.
But yes, it was awesome. We talked about syndesmosis injuries, which we go into in a lot of depth in the podcast. But, I've always thought of syndesmosis injuries just to be an injury to the membrane between the tibia and the fibula. So it's really cool. And I've recently realised that that's not the case, but it was great to actually hear the ins and outs of that and the management for it, the treatment for it, the orthopedic decision-making process around it. So yeah, Steve's knowledge around this area is very
good, knowledgeable guy. And I tell you what, he's made, he just presents and talks so well. So follow him on Instagram. We've tagged him a couple of times on our Instagram, and he's also got a YouTube channel, and it's pretty good.
Does he actually draw those pictures?
Yeah, he was explaining to me how he did it. I don't want to butcher it because I can't remember, but there's some app and way that you can do it. No, he doesn't draw it. There's like a way that...
He's like an artist also.
Yeah, it's really, really cool. So yeah, he's got like over 1,000 subscribers. It's really, really good. And what I love, and another reason, like with this podcast, like you just don't get... I haven't listened to too many podcasts with foot and ankle orthopedic surgeons, and like that's somewhere or something when you're a student or a younger grad or even a clinician, you just don't get that access to. So I just love that we're able to be, I guess, the surrogate for people to then hear that information, which is awesome. So anyway, awesome episode. We'll be doing part 1 today, and then we'll be doing part 2 next week, because I think that it's better having just a smaller bite of information, just because you can take it in more. And if you want to listen to it on repeat, you can, which obviously we always do. But moving on to our next couple of new topics: Kelly's high, Kelly's low, my high, my low, and we're going to add in a new segment, which is...
Oh, yeah. Okay. So...
Far out. Get pumped. Questionable information, which is, I think...
I didn't know you wanted me to read. I thought we were saving that till the end.
Yeah, but I was pointing to it. I was just...
Are we saying that now?
I was just warming them up for it. We're going to do it in about a couple of minutes, but I was just warming them up.
Questionable information that we've seen on the interweb.
Yeah, on the interweb, on the dial-up. Yeah, questionable information. So, but we'll start with Kelly. What's your high? You're happy. You've had a good couple of weeks.
I've been back running. So a few episodes ago, my shins flared up after Blackmore's. Just thought I was a bit more invincible than what I am. But I was a really good patient for the most part and settled it down very quickly, I hope. Hopefully this continues. But yes, I've been back running this week, almost back to my full running volume. Haven't had any pain at all this week. Just been doing really slow runs. I haven't done any... Oh, I did a hill session on Tuesday, but still not fast running hills. But yeah, ran 21Ks this morning and felt good.
Yeah, felt good. So what did you do initially when it flared up? Because I know there's a lot of runners that listen to this, and we know running injuries are incredibly common. What would be your general recommendation, other than obviously avoiding that intensity for a period of time? What would be your recommendation if someone was to feel that discomfort and they've had a previous history?
Well, so I just don't think shin pain is one that you can run through. That could be a blind spot of mine, but I'm pretty happy to say just stop as soon as you feel any form of shin pain, because given it's a continuum, right? So it moves along that trajectory towards a stress fracture. So I just don't think that running through discomfort has much merit. And I think if you stop as soon as you start to feel your symptoms, you probably can settle it down relatively quickly. It was 5 days that I had off running, and then I started running again. But then, it's just been very easy, slow runs, which I'm totally fine with. I just love being out and running, and I don't really care that I'm not running fast. I love to just chat and feel comfortable. So that's what I'm doing at the moment. I'm thinking about maybe doing a faster session on Tuesday, but could also just do hills again if I'm not quite feeling up for it. We'll see. Yeah.
And your low of the week?
My low of the week was that, it's a bit of a high and a low. So the Ironman World Championships have been on, which were on Friday and on today. So the women were on Friday and the men were on today. And it was awesome to watch. They're just such incredible athletes, and I really love watching them. And I love that they spread the men's and the women's race over 2 days. I do feel as though the women, if they're in a combined event, they're often the supporting act for the men. And I think that they've got having full coverage is amazing. But my low was that the two people that I was really gunning for, and I just love everything about them. I think they're great athletes. I think they're really cool people. Joe Skipper and Laura Phillips. I really wanted them to at least podium, and neither of them did, but they were both so close.
Why do you like Laura Phillips? I haven't heard you talk much about her.
She's just a really, I don't know, she seems like a very nice person.
She's Australian?
She's German, I
think. Right.
I just follow her on Instagram, and she just seems like a nice person, and I just like her.
Yeah, that's ridiculous. Hey, running 2:35 marathons after a 180k ride, it's crazy. But
it looked hot.
Yeah, it did look hot.
And the men, they're just so close. They're such incredible athletes. 16 or 19 men got out of the swim at the exact same time and straight onto the bike. Like that, there was over 4 kilometers. They just did. They're all just at that top.
I guess that, but level. With the swimming, you're
kind of
drafting a lot. Yeah, and there's true. No, like, if you're sitting second, unless you're like a weapon swimmer, I don't think there's any value in coming out, because then you lose that drag and you've got to put in that effort.
Yeah.
I don't know. I wouldn't ask myself triathlon advice ever. But that was really good. I
really liked watching it though. I thought it was good to watch. Blake, what was your highs?
My high this week, and I'm excited to get this out on the Instagram, is I think I've created some form of a concept to think about for footwear prescription. So I definitely get quite vocal on our Instagram talking about minimalist versus maximalist shoes, and there's people on one end of the spectrum that are always gunning for the minimalist shoe, and there's people on the other end that are gunning for the support and the maximalist shoe. So I think I've kind of hit somewhat of a middle ground, and like you said with Bone, it's a continuum, but I've also added another thing. So you imagine, and you'll see it on the Instagram, sideways continuum, maximalist and minimalist, but then there's another axis which I think would be the y-axis, and that's reliance and non-reliance, because there are times when people will benefit from supportive orthotics and really supportive shoes, both in the short term, and there's also people that will possibly do better with them forever. So that was really exciting. And also been having some cracking conversation with Michael Nishke. We did a podcast episode with him not long ago, and Adam Did? I can't pronounce his last name.
Didick?
Yeah, I don't know if he listens to this, but he's going to be butchering. But I'll try and save it by saying he's an incredibly smart guy. And he was on the Stronger Stride podcast. He coaches Jess Stenson. Yeah, I put up this thing asking some running advice, and he replied with an article and some good information. God, I really like that. So don't think he listens, but that was awesome. And we're finally booked a podcast with the Foot Collective, which is going to be exciting, which will hopefully be the start of November.
Okay, cool.
Yeah.
I'm the moderator.
You're the moderator, which is going to be good. So my low...
I'm a bit nervous.
Yeah, it's a lot of research to read, but I'm excited. I don't think he listens to this. Nick, his name is, but it'll be really, really good. We just want it to be a good resource for people for... Yeah, and it's not going to be a boxing match where we just rip on each other and say how this is better and this is worse. It's just presenting the findings, presenting the research, and then someone interpreting that, and you make your own decision.
Yeah. Cool. What was your low? Low
was my knee was sore. Got ITB on the left side, and it sucks. It's painful. Real painful.
You're just such a resilient... Your
it's
body
sore, but
is
it's okay.
So resilient.
Yeah, it's sore, but it's fine. I took a couple anti-inflammatories, which I never, ever do.
That. You took the strong ones too.
Yeah, but like for a couple of days, and it's fine now. And I did a 28k run today with a couple of efforts, and it feels all right now. A little bit sore, but it'll be fine. But I could imagine if that was any more sore, you can't run through that. Different with like a tendinopathy. So that I feel for the people that have had that out there. And
what do you think? If you could go back over the last 1 month of your training, do you think that there's anything that you would do differently to try to mitigate the risk of that flaring up? I know we can't prevent it, but is there anything that you have sort of on reflection thought maybe that's why my knee is a bit sore now?
Well, I had no pain, and then last Saturday I did 30k in one day. I did a really fast effort in the morning, well, fast for me, and then did 50, and then another 15k in the afternoon.
So you wouldn't have done that run in the afternoon if you'd go back?
No, I wouldn't have. But...
Who told you not to do that run?
You were right. You told me not to do it, but I still did it, and I probably shouldn't have. But I had missed a day, and I just wanted my Strava to look really cool. I wanted to get that 80 and then that 90, but yeah, that was definitely... It was a contributing factor, definitely, but it may not have been the whole picture. Anyway.
Do you think that... posting about that on your Strava and saying that you're managing it with like Advil and stuff is misleading to the patients that follow you on your Strava?
I thought it was more of a meme.
Yeah.
Or well, I didn't say that I
know that.
Yeah.
But some people might not.
Yeah, that's true. Maybe I shouldn't have done that. If you're a patient listening to this eating any inflammatories because of me, which I very highly doubt, I thought it was a funny meme, and I really enjoy memes. But yeah, I hope not. I hope they're not out there going to their doctors saying, look at this meme, can I get some anti-inflammatories for my knee? But the other low was I had a bit of a realization this week about how I question patients when I'm talking with them, and the more so the questions I ask, and how the quality of the question really determines the information. And I won't spend much time on this, but a quick example, asking someone to rate their pain out of 10 at its worst, someone could say an 8 or a 9 or a 7 out of 10, which we would interpret as quite painful. But what I'm finding is, and this is just an example, asking a better question, has it gotten to a point where it stopped you from doing something, is probably a better way, because they could say it's an 8 out of 10, but they're still running all their volume, they're still doing everything they love to do. So, that 8 out of 10 may change how aggressive we are with our treatment. Whereas if it's to a point where it's not affecting their meaningful activity, it may mean that we might not have to rebook them as soon, or we might be changing our rehab a little bit different. So that was a good one. So questioning is important, because the quality of your question determines the quality of your answer.
Especially for those kinds of injuries, like tendon injuries, where we know that it's kind of okay to run through, and we also know that a lot of patients don't have a great understanding of how to answer that question, like what their pain rating is on a scale of 0 to 10. So you could ask someone who's running and hasn't changed their running, for example, like, how painful is your tendon pain? If they say 8 out of 10, then that might make me want to change their running volume a little bit. But if it's not to the point where they're changing like their volume, their intensity or frequency or anything like that, then maybe that's just their not being as clear on like how to actually answer that question well.
Yeah, and you go through a lot of questions, a lot of information, and of course they've thought about their injury, but they probably haven't thought about it in the way that you want them to think about it. So I think that's really important. Cool. So new segment, questionable information. Kelly, take it away.
So Lucy Charles Barclay is a Ironman athlete who just raced in Kona Ironman World Championships, and she has a YouTube channel and recently had a femoral stress fracture. And I was watching one of her YouTube videos, which was titled "What was the true cause of my stress fracture?" And I'm not saying that it's wrong, but we're questioning, how do you actually know that that is correct? So what she was saying was that the reason that she developed her femoral stress fracture was because that particular side had a slight increased degree of pronation when she was running, and because with her swimming she's only ever breathed to one side rather than breathing equally left and right, which has contributed to like glute tightness and a slight scoliosis within her spine. And those sorts of things have been the true cause of her stress fracture. She commented on the fact that it's definitely not her load, it's definitely not nutrition, because they checked all of that. But my question to all of that is, like, how do you know that those are the things that caused it? Like, what is going to pull those biomechanical factors out and say this is the only possible thing that could be causing that problem?
Yeah. Completely agree. That our problem with it is the information that they provide, and then people, because she's got quite a few followers on YouTube, and people take that information and then they focus on it, and then they start analysing themselves, and other people or clinicians start doing it, and like that's such a high hanging fruit. That fruit is at the top of the tree. Like, and even there's just so many issues. So, like you were saying, how do you even know? And then if you're so certain, how the hell are you measuring that? And how, like, just the degree of pronation, like on what surface, in what shoes, at what time of the day, there's so many, under what level of fatigue, like, that's just, it's so frustrating to see that kind of stuff from a professional athlete.
And how do you know that your training load, even if it hasn't increased by arbitrarily, like, more than 10% or whatever, how do you know that that's not having some influence on this developing? Like, surely that's got to have some sort of contribution to, because it's a load related injury, right? And then plus all the other factors that we know are more relevant in sort of
like
female femoral stress fractures.
And I'm sure they checked all that stuff, but even just that was. And
then reading the comments of the YouTube video as well from athletes who are saying like, oh, thank you for sharing this information, like this is so helpful to know that, and it's like, that's just such shit. Like, I'm not saying that they aren't factors. Like, maybe they are factors within a bigger picture, but I don't think that you can say that those are the only things that caused it.
Yeah, and as well, people obviously like different industries in the world. Like we know lots and lots about health because we're in the industry. If I was to watch, say, you're thinking of an engineering industry or the trade industry, something you don't know a lot about. If you were to go and watch a video on that, and it's someone that's really high up, the best engineer in the world, and they say, or probably not the best engineer in the world, but someone that's in the engineering space, and they say something to you take it as gospel because you don't know really much about it. So people and athletes are watching this going, I don't really know too much about the body and things like that.
So it must be right.
Yeah, I'll just take what she said. It has to be right. And then, they go to therapists. They go on, I don't even know what they do. But yeah, it's frustrating to see that. So those factors, like Kelly said, they may play a role, but on the whole spectrum of treatment as to what's contributing, very, very far down the side of not a big contributor. Mm-hmm. Would you agree?
I would agree, definitely.
Yeah, great. We agreed on something. Well, let's end it there.
Yeah, let's finish on a good note.
Awesome. So, guys, enjoy this episode with Dr. Stephen Kent, and we'll talk to you guys next week.
Welcome back to another episode of the Sports Medicine Project. We have a return guest, our first return guest. Maybe not. Justin might be a return guest.
No, first proper guest. First return guest.
Justin's not a proper guest.
Yeah.
We have Dr. Stephen Kent with us, part 2 on syndesmosis injuries. So we talked about syndesmosis injuries briefly in the last episode, and we were keen to really pick Steve's brain. So welcome.
Oh, thank you. Thanks so much for having me back. I'm glad I'm seen as a proper guest, and I'll let Justin know that he's not a proper member. No, really glad to be back. I was really keen to be back. I wondered how the last one went, so it must have gone okay, I guess, to be back.
Yes, it did really well. Yeah. And a lot of the case studies as well, it was good. I think we got more feedback from our younger clinicians, which was good, because like we said in the first one, people just don't get that opportunity to hear from an orthopedic specialist, and hear what your week looked like, how you treat patients, what surgery involves, that kind of thing, which was awesome.
Yeah, great. Yeah, no, look, I think what I've actually realised in listening to you guys is there's a big disconnect between, say, where the surgeons are or specialists are, and then, say, sports docs, and then podiatrists, allied health, physios. It's quite like I was listening to your podcast with Justin the other day about sort of imaging, right? And we see a lot of the imaging that comes to us ultimately, and it's not ordered by podiatrists, I'm not saying, but in general, a lot of the imaging actually we then reorder. Right. Yep. So I was talking about my colleagues the other day, there's a lot of wasted money in terms of imaging. And so it's not wrong to order imaging by any means, but it just showed me there was probably a spot, all the stuff you guys talked about was great, but there's a real deficit in terms of us trying to get messages out to everyone else around in terms of educating and talking about that sort of stuff so we're all on the same page, because there really is a real disconnect between each sort of level of care, which is getting better and better, and podcasts like yours are making that much, much, much easier. But probably it should be an onus on us surgeons or specialists to be out here doing this sort of stuff, I think, because it really helps, and ultimately it's better for patients, right? So and that's what the great thing about your podcast is you've got a whole different range of guests. So I love listening to, I was going to say I listen to a lot of them. So and I learned a lot from Nikki's one the other week too. So
that was a good one.
That was good. Yeah, I really appreciate that. It's great. And like we were saying with the imaging, I mean, you don't know what you don't know. You can think this is the best imaging modality for this, but I mean, you don't know really.
No, look, trust me, we get it wrong too. And the lucky thing we've got is that often we get a Medicare rebate for our imaging. Okay, so there's less pressure for us not to do it. As in, we just write a form and it'll get done. And so we've got to be really mindful too, sort of the gatekeepers in terms of that, in terms of the cost to the whole healthcare system. And so you really do, if you're going to order a test, and you guys made a good point, MRI, so you could MRI everybody, and you would find about 5 different things that would be reported on the image that actually don't matter. But if the patient listens to that or reads it, or it's interpreted by the wrong person, that can cause real damage in terms of their beliefs and ongoing care, et cetera, et cetera. So, I mean, classic one of those things like discs in back pain and things like that. So I think talk about that sort of stuff is fantastic. And as long as we're all on the same page, then that's fine. So, and I think more we all engage together is helpful.
That's the better. Now, for our new listeners, so whereabouts do you work? What kind of work do you do? What's been your story, and how did you end up, practicing where you are now?
Yeah, so we went into a little bit last time. So I'm based in Newcastle, New South Wales, Australia. I operate predominantly in the private hospitals, Lake Macquarie Private Moynes Bay. I'm a foot and ankle orthopedic surgeon. So that means I'm trained in all aspects of orthopedics, but I've gone down sort of a subspecialist foot and ankle pathway. And my interest is particularly foot and ankle sports injuries, one of which is syndesmosis that we're talking about today. And then in terms of back in my training, I trained predominantly in Newcastle for my orthopedic training. And then went over to Brisbane to do some what's called a foot and ankle fellowship. So look at a lot of sports-based foot and ankle work up there with a lot of professional sports teams and some very excellent foot and ankle surgeons up there. And then went over to Toronto in Canada in what was supposed to be 6 months, but had to leave about halfway through for another fellowship over there. Left halfway through because of COVID, essentially, and then started up practice here in Newcastle in the middle of 2020, well, early 2020, when no elective surgery was going on. So that was a great start. Yeah. So, and I do on call at the local private hospital, Lake Macquarie Private. So I do a lot of fractures all over the body, not just the foot and ankle, but my predominant elective work. So people that come through my door to see me in my office is foot and ankle based work.
Yeah, very nice. And yeah, today's topic is syndesmotic injuries. I'm really intrigued. I know Kelly's going to be the driver of this conversation. I mean, in podiatry, we typically don't see those acute, I guess, ankle sprains. They present to physio a lot more than podiatry. So I'm really interested to see, and really, I mean, I don't know much about them at all, just because I don't see them that much, only what I've read. So I'm really interested to hear, what you two are going to talk about, and me just kind of sit in the back seat and learn a lot, which will be good.
Yeah, I'm really interested as well, because I've probably over the more recent months and probably a lot of it since seeing a lot of your patients, Steve, but I've always thought that syndesmosis injuries were just like a membrane, like the tear or an injury to the membrane between the tibia and fibula. And I now understand that that's a bit of, well, syndesmosis injuries are a bit more of an umbrella term, and there's lots of different things that can fall under that. So I'm really keen to hear about some of those more common presentations, or maybe not so common presentations, and a little bit of the anatomy around the syndesmosis.
Yeah, excellent. Yeah, it's a very little known topic, really. I'd say even orthopedic surgeons, there's a percentage of syndesmosis injuries we actually don't get taught about, funnily enough. We all know the anatomy, but my colleagues, when they're training, the registrars coming through, they will not see many of what we call soft tissue syndesmosis injuries, meaning that what's done in the NRL on a weekend basis, they wouldn't have seen, possibly not seen one, or they would have seen them in ED and thought they were a typical ankle sprain. So it's not a well-known injury outside of really a foot and ankle domain, funnily enough, and physio domain, really.
Yeah. So what's the specifics? Like, what is the syndesmosis? What is that whole area, and what does it involve?
Yeah. So syndesmosis is an area at the ankle, essentially, right? So it's the join between the tibia and the fibula down at the ankle. And so that's and basically the tibia has got a bite out of it, a groove, which the fibula sits in. And then it's held in that groove by 3 ligaments. One at the front, holding the 2 together, one at the back holding the 2 together, and then one actually between the bones that holds them together. And then obviously as you go further up above the ankle, there's a membrane called the interosseous membrane, which holds the fibula and tibia together all the way up to the level of your knee. And then there's another joint of ligaments up near the knee where meets the fibula. And that's not the syndesmosis all the way at the top, but essentially the syndesmosis complex extends all the way from the interosseous membrane down to the ankle where those other 3 ligaments are. And it's an incredibly important part of your body, essentially. So if you rupture maybe one of those 3 ligaments, you might be okay in terms of long-term effects to your ankle. But if you injure any more than that, there's reasonable biomechanical evidence that would suggest that you may have long-term issues with your ankle as a result. Okay. And so the reason we call it it's known as a high ankle sprain, is because it's an injury to ligaments at the ankle, but it's at a higher level than we typically see in an ankle sprain. So the ligaments that we're commonly looking at in a typical ankle sprain, where you roll your ankle, say playing soccer or football, or you roll it down a gutter, typically they're further down where the fibula actually attaches to another bone in your ankle called the talus. And they're really common, as we talked about in one of your other podcasts. But the high ankle sprain probably makes up about 1 in 4 injuries in contact sports. So it's not actually that uncommon. And there was a study done recently in European soccer that said about 75% of those injuries are made up in a collision or a tackle. Okay, so typically they're going to be in positions where you're playing sport or doing something where you come into contact with something rather than just twist the ankle, although it can happen with just a simple twist. And the mechanism is different, which we can go into. But essentially, you've got a ligament at the front called the AITFL, or for a long name, anterior inferior tibiofibular ligament. No one's going to remember this, but basically the front one is known as the AITFL. The back one is called the PITFL because the back is posterior, that's the P. And the one in the middle is called the interosseous ligament. And so the single most important one of the whole lot is the posterior one. It's the strongest. It's the hardest one to basically get rid of or break. The other two usually have to go to get to that. Just a quick tip for anyone that's gets an image of the ankle. So that can be an ultrasound or an MRI, and they're reading the report, and they just see all this garbage in the report, and lots of names, look at medical jargon. If they talk about a ligament and it's got an I in it, and what I mean by that is if they talk about AITFL, because just to confuse things, the typical ligament you'll injure further down in a typical ankle sprain is called the ATFL. Okay, if the ligament's got an I in it, then that's the syndesmosis, and you should be more worried. Okay, or if they call it the anterior inferior, so hardly ever they put that inferior in after an anterior with a ligament other than the syndesmosis. Okay, so if it's an anterior inferior, tibiofibular, so any tibiofibular ligaments, so ligaments between the tibia and the fibula are ones to worry about. That's the syndesmosis. Right. When they talk about talo, so the talus, and then going from the talus to the fibula, that's further down, and that's typically a low ankle sprain. So it's really confusing, right? Like really confusing. But basically, if there's any abbreviation in there with an I in it, be worried about a syndesmosis. Or if they talk about anything between the tibia and the fibula as a ligament, be worried about it based on imaging. Okay, and maybe you need to have a chat with someone like a sports physician or a surgeon about whether that's an injury that might need to be treated with surgery, possibly. So that's a lot.
You mentioned biomechanical changes if these aren't managed. What are they?
Yeah, so there's been studies where they've taken cadavers and so they've put them in basically they've held them constrained, they've cut the ligaments from front to back, and then they've applied an axial force, and then differently they've then applied an axial force with external rotation. So I see patients that have had what I see on MRI as a really bad syndesmosis history, which I would have thought they'd be limping in, hardly walking. They're 3 or 4 weeks down the track, and they say to me, "It's really good." Like, really, is it that bad? Like, why am I walking around here with no pain? The biomechanical changes actually show that if you go through, say, just the AITFL, the center of pressure through your ankle actually probably doesn't change all that much. So mechanically it changes a little bit, but not hugely. And so we think that probably doesn't make a massive clinical difference. Once you go through the interosseous ligament as well, or you go through the interosseous ligament plus the PITFL, the one at the back. So if you have more than one ligament injury, if you've got 2 or 3, then what you see is that the center of pressure that runs through the ankle in a lab actually starts to move posterior laterally. So it goes from being in the middle, and it can move up to 6 millimeters posteriorly. So it moves a lot. So that's in a lab condition. So that's not a real person, and that happens that only happens with external rotation as well. So that's why I think I see patients that are actually pretty good when they walk through my rooms, yet their MRI looks pretty terrible. So because just an axial load, the actual congruence of the ankle is maintained, even if you've gone through all 3 syndesmosis ligaments. And so what you're basically worried about is if you ruptured all 3, that fibula can move around. That's the worry, and that means the joint's loading abnormally. So what we know is if we cut 2 of them, we already start to see the center of pressure move, and when we cut 3, it moves further. So what we think from that is your cartilage that's made in your talus bone and in your tibia is at different thicknesses at different areas. Okay, and so it's made that way because that's how, when everything's intact, that's how it's loaded. Okay, but if you change where most of the pressure is going through in the talus, and all of a sudden you start to load an area that's not quite as thick, for instance, you would worry. And we don't have. There's not a study that says we looked at everyone that had a syndesmosis injury and we saw how many had arthritis 20 years down the track. There is not a study on that. So I can't say on this podcast, you have a syndesmosis injury and it's not treated, you'll get arthritis. I can't say that. Absolutely. Or you'll get emails that say, well, he's lying, or there's no evidence to prove that.
Yeah.
Right? But I would worry. If it was my ankle, I would worry that if I've gone through more than 2 ligaments, I want to know if my fibula is stable. That's for me, right? And I would worry for that for my family as well. That I know from that biomechanical data that it's worrying, that the center of pressure does change. And so anytime that if I'm a rugby league player, for instance, I'm going to have a lot of external rotation forces when I'm being tackled, when I'm pivoting, that sort of stuff. And if that's happening to my ankle over a long time, if it was left alone, is that going to mean, I would worry then that potentially extrapolates to you getting a long-term issue like arthritis or something like that. But more importantly, what we know from syndesmosis injuries that are not treated, they're a higher risk of having what's termed as long-term ankle dysfunction, which essentially means ankle doesn't feel right, either feels unstable or painful, or is impacting their life, basically.
So is that the risk why, compared to ACLs and Achilles and things, non-operative versus operative, is that why it's such a high risk injury earlier on?
Well, it's actually quite a controversial injury. It really is. You can pick another surgeon on this podcast and you probably get a different opinion, if I'm being honest with you, right? So there are groups of surgeons like myself who worry about it a lot and are reasonably aggressive with them, okay? And then there are other groups of surgeons that feel they should be treated similarly to low ankle sprains, and they should be allowed to sort of let run, see how they feel symptomatically. And if they then develop ongoing symptoms, basically, then maybe they should be treated. So there's different, and the reason for that is there's a paucity of evidence in terms of long-term problems. Because no one's really studied it. So there are studies that show that if you compare low ankle sprains to high ankle sprains, they're more likely, say, to maybe have long-term pain or issues getting back to sport or something like that. But we don't have any long-term data that says they get arthritis. We don't really know, to be honest. And so that's why you might go to, and I've had patients myself that have gone and seen another surgeon and been treated non-operatively, and they come around to me after not getting better or something. But I've also seen patients that are like 12 weeks down the track that on their MRI, they've had they've gone through all 3 ligaments and they're feeling fine. And they say to me, do I really need surgery? And that's a hard conversation, because I say, well, I would worry long-term, but I don't actually have any proof of that. That's just my thinking based on the biomechanical data. And so that's where it actually becomes tricky, and that's why you'll get some differing opinions on that. But you'll see all the sports stars, they all get treated, they all get operations, all of them. Okay. And if I sort of feel like if it's good enough for that, well, I don't treat it just because they get it. I think the biomechanical data makes me worry a lot, and so as a result, I treat them. The other thing is, lastly, I'm going on a bit, but we know for ankle fractures where there's a syndesmosis injury as well, if the syndesmosis is not sitting in the right spot with those fractures, there's evidence proven in studies on that they are more likely to get arthritis, and they are more likely to have some ongoing issues in terms of pain. So we know from a fracture point of view, if we don't put the syndesmosis where it should be, that they get long-term problems. But it hasn't been applied to those ones where the fracture's not involved.
Yeah.
Right.
Interesting. So I wanted to ask, I know it's a two-part question. How commonly do you see them missed? And then, depending on that answer, what kind of clinical presentations do you see to then make you more suspicious? Like, this is definitely, needs to see yourself, or sports doctors on needs further imaging.
Yep. So I say, the literature would say they missed in 20%. I see missed. I guess what I can say to you is I rarely get them referred directly from a GP. I typically get them referred, if they come to, and I would think I would see more than others because that's my area of interest, but I typically have them referred through a physio. Physios picked it up more often than not. They're much more aware of the injury, just through the difference in training than the general practitioners. It's just not that well known. Yeah. I probably see maybe 1 out of maybe 5 or 6 through my practice that's missed. and that falls into that sort of subacute or chronic group, I guess. But the literature would say 1 in every 5 at least is missed. The reason they're missed is they're actually very hard to diagnose. So the reason they're easy to diagnose in the sports stars is because you actually see the mechanism of injury on a video, which we don't. When patients come into you, Kelly, I'm sure most of them can't see which way their ankle went when they did the injury. So the things so typically how you do a syndesmosis injury is it's got to be usually a dorsiflexion and external rotation mechanism, which is the opposite from a typical ankle sprain, which is usually an inversion type injury. Okay, the patient won't always know, and that's half the problem. And the other problem is that you're typically looking for tenderness over the syndesmosis itself, which is over the sort of anterolateral aspect of the ankle where the tibia meets the fibula. That's where you're looking for the tenderness. And then you're also looking for potentially tenderness further up the interosseous membrane. So we know, for instance, that if the tenderness goes, say, more than 5 centimeters above, if someone's playing sport, that actually affects the amount of time they get back. So if you've got an injury to the interosseous membrane, it's much more likely to be a more problematic injury. So the problem, though, is that you can have tenderness over the syndesmosis in about between 40 and 60% of low ankle sprains. So ankle sprains where there's actually not an injury to the syndesmosis, which is very confusing. So if you just went off the tenderness alone, that doesn't really tell you whether they've got a syndesmosis injury or not. If they're not tender over the syndesmosis, then they're not going to have one. But just if they do, it doesn't necessarily mean that that's the injury. So you're looking, which is really confusing. Okay, so basically, number one, you're looking for the injury. If the patient describes an external rotation, so an eversion type of injury, that's pretty likely to be a syndesmosis injury. That should have a high suspicion to begin with. Okay, if they're playing a contact sport, like I said before, the contact sports are more likely. We've recently seen like the hip drop tackle in the NRL. That's typically how they've been done lately in the NRL. So contact sport, that should also prick your ears up. That it's much more, it was in contact, like a tackle playing soccer, tackle playing rugby league, rugby union, much more likely to be a syndesmosis injury. All right. They're the two. You have to examine for tenderness. So if they're tender over the syndesmosis, all we can say is it might be, but it may not. Okay. And then you've got your special tests, which are what's called an external rotation test, which basically means very firmly bringing the patient into external rotation while holding the tibia, and you're looking for pain as a positive sign. And then the other one is something called the syndesmotic squeeze test, which is done about 8 to 10 centimeters above the level of the ankle, and you basically squeeze the tibia and fibula together, and you basically try to provoke pain. Now, the problem with those tests is they're not particularly accurate, as in they're not specific. So they can be, I definitely have seen patients that had very positive tests, didn't have a syndesmosis. Okay. They're useful. They're sort of giving you some information, but they're not going to say, yeah, if you've got this, you've definitely got the injury. They just sort of add to your clinical suspicion. Okay. And so all you can do is sort of really realistically those 4 or 5 things. Okay. That doesn't give you an awful lot of information realistically. The kickers are the external rotation injury, really. That's the big one. And I would place some value in the special tests, but once again, not 100%. If they're not in one of those sort of high-risk categories like a rugby league player, soccer, etc., then you probably can actually see where they're at maybe 3 or 4 weeks down the track. Okay, because a lot of our ankle sprains, typical low ankle sprains, are starting to get better with some rehab by that point. And you haven't really missed the boat to treat a syndesmosis injury anyway. If you've got a patient then that's really not getting better and their pain is very much over that anterolateral ankle still, then that would add weight to their possibility of being a syndesmosis injury. Okay, and that might be a time where you might think of either another opinion or some higher level imaging, which particularly with syndesmosis injury is an MRI. If you look in, on the internet or in books, they typically talk about an X-ray looking at spaces around the ankle. Okay, things like tibiofibular clear space and that sort of stuff. That's the traditional teaching. The X-ray will pick up a howler, basically, meaning that if there's a big gap between the tibia and the fibula, or if there's a big gap on the medial side between the medial malleolus and the talus, that they'll pick that up. It'll look really wide and really obvious, and it'll pick those ones up. But as for measuring little distances on an X-ray and trying to work out if it's 2 millimeters more or something to the other side, the accuracy of that's been shown to be really poor. And the reason for that is poor radiographer can't put the feet in exactly the same position every time. Like, that's not going to happen. Like, I can't do that when the patient's asleep and get the same X-ray on both sides all the time. So the radiographer, the patient awake, is not going to be able to do that easily or accurately. The other thing is that it's not just it's been shown in studies that you can't reproduce it person to person, as in everyone measures something different. So and it's also been shown not to correlate with the MRI findings. So you can have a 3 ligament rupture on an MRI, and the X-ray will look pretty normal. A weight-bearing X-ray will look normal. The other thing is the fibula usually translates posteriorly in the injury. So we've typically been looking for it to move sideways when actually it moves front to back. And so the X-ray is not great at picking that up either. So I would still recommend X-rays, because if you miss a fracture, then that is really bad, and they will present very, very similarly. So an X-ray is still valuable, definitely as a first-line investigation. But all I'm saying is if the X-ray is normal, or you're trying to pick up different little gaps based on measurements, then you can't rule out a syndesmosis injury on an X-ray.
I'm really glad you said that, because that's something that I've routinely done, is sent for bilateral weight-bearing X-rays to rule out a syndesmosis injury. And it's something that I've always questioned, because I've thought, like, if this is a really bad syndesmosis injury, maybe it will show something. But if it's a minor one, it's probably not going to show anything. So what am I actually doing it for? So I'm really happy that you said that.
I wouldn't go straight to, I said, like, I think I did this the other part. Like, I don't want to send on a message being, go MRI, everyone, you worry about syndesmosis injury. Like, because that's bad. So I just think you should get an X-ray first. There's no one, I can see, because there's no one I definitely do X-ray, and I definitely want to weight beam X-ray. And there have been 1 or 2 occasions where there's been a fracture picked up. Okay. I know we haven't talked, this is another topic, but it's something called a major nerve injury, which is a fracture associated with the syndesmosis injury. And that can present that way. And so you'd need to do an X-ray. I guess you just can't rule it out. Okay. So definitely, people you're worried about syndesmosis injury, please X-ray them, because you don't want to miss a fracture, because they present very similarly. But you just can't rule it out based on an X-ray alone. That's all.
Yeah, it's good. Like, and this is like we were saying, and we were saying at the start, having, the podcast previously with Justin, just talking about imaging, there's so much more complexity to these things, that one, what you're taught, and also what's in the textbook. Like, I know for most people, this is going to be completely new information, and they would assume, weight-bearing X-ray, that's what you really need to get. But knowing that there's certain times where it is more beneficial compared to an MRI, and then a combination of them both. So, that's where your specialty, obviously yourself and doctors and things comes into it.
Yeah, look, there's other things. So if you go look up the literature, like even reading papers, so if you look up the literature, so ultrasound is actually in the literature said to be very accurate for picking up the injury as well. The problem is that but those studies are usually done in sports centers, where the sonographer is just looking at ankles all the time, or ankles and knees. So their level of expertise is fantastic, because they're looking at anatomy under an ultrasound all the time. Okay, Australian radiographers, ultrasonographers are excellent. They're really, really, really
close
good.
This door.
You're right.
So we'll edit that out. That's okay. That door.
They're really good, but they're doing a range of pathology. So they could be looking at pregnancy one day. They could be looking at wrists. They could be looking at hearts. So they're excellent at what they do, but they might only be doing an ultrasound for a syndesmosis once every couple of weeks or something. And so I guess from my point of view, I don't place a lot of value in the ultrasound, because it's what we call user dependent, meaning that I actually can't really read the images when they send them to me later. You actually need to be there at the time to look at it and make an interpretation. And so the difference, I guess, with an MRI for me is I can look at it, look at the image and say, well, yeah, I can see where those ruptures are, and show the patient and know that, I guess you're basing information on what I can see in my interpretation of it. Whereas a sonographer, it's ultrasound, unfortunately, is very much user dependent. So you can't extrapolate the studies that show it's really good. That means as a tool, it's really good in the right hands.
Yeah.
But you can't generalize it for everything. So each modality, actually, you've got ultrasound MRI are probably both pretty good, but the ultrasound in particular is going to be very dependent on who's doing it and where you're getting it. So if you're getting it at, a place called Aspetar, which is the place that looks after all the FIFA injuries, then that's probably really good. You can place great faith in that, and it'd be much cheaper. So, but we probably can't extrapolate that to here. Yeah.
What would you recommend? And I know it's incredibly hard and complex to answer this question, but if someone is suspicious of a syndesmosis injury, what would be? Do you think it's best management? Again, depending on the severity, to send to someone like yourself or a sports doctor initially, or for them to order the right imaging, or what do you think? Because obviously I can see the benefit and the con, but what would be your opinion on that?
Oh, it's actually really hard to give good advice on that. My advice, most of the physios I tend to say, look, if you really worry about syndesmosis injury, just give me a call and I'll get them in. I think if you're worried about it, I think those ones, there is a bit of information to say if you get them within 6 weeks, that they're likely to do better, say if you get them a bit after that, in terms of for the ones that need to be done surgically. So my take on that is, because there's such an airy-fairy type of diagnosis, realistically, so unless you're pretty confident based on mechanism, what the patient's told you, history and risk factors, I would probably, if you're worried about it at 3, 4, 5 week mark, I would refer it on at that point the only imaging I would say is get an X-ray.
Yeah.
That's all I would say at that point. And then let that next person work out based on the referral. Because typically if I get that referral from a GP or a physio or a sports physician, I will order the MRI based on that history before I see the patient more often, if the history is strong for it. So, and that's more actually just from a point of view of trying not to waste imaging money and modalities and that sort of stuff. In a perfect world, for ligamentous and most things, you'd MRI them so you know what's going on straight away.
MRI in the corner of the clinic room every time.
Yeah, but you can't do that for a resource point. The other thing you'd find things you're not trying to, like I had a kid who wanted to go play a futsal tournament overseas or something, and I was positive he had a low ankle sprain, but I just needed to rule out sort of like a growth plate injury or something, so we could just rehab him faster. And lo and behold, I found something else I wasn't planning to find on the MRI.
Yeah, that was weird. I know who you're talking about.
Yeah. So there is dangers to over investigating as well. Okay, so I think for those high level tests, unless you're, say you've got some games in first grade in local regions now telecast on YouTube, whatever. Unless you've seen the mechanism, like, oh yeah, he definitely externally rotated there. That's going to be syndesmosis. Okay, I'll order that MRI. That in that situation, yeah, sure. But I'd probably leave it to the next person. If you're a reason, like for me, I get them in fast and I like seeing them and it's my thing, so I have no issue with that. I would imagine most surgeons for that type of injury would be happy to get them in quickly. To me, it's like equivalent of an Achilles or something like that. It's not something that they're going to say, you shouldn't have sent me here you shouldn't have sent that patient on without imaging kind of thing. I think as long as you've got an X-ray, I think that's enough. Yeah.
Yeah, God, I tell you what, those contact sports, I'll be sticking to running. That's why running's the best. There's no one hit me from the side or my ankle.
Well, you never know. If you're down a hill or something like that, slip like wet grounds. Someone treads on your leg as you and rolls it outwards. It can happen.
Right. Come on, mate. Give me a little bit of
likely.
I'll be strapping my ankles. I'll be casting it, bloody orthotics and everything over the top this afternoon. And moving a little bit more to the rehab side. And I know Kelly, like you've definitely rehabbed way more syndesmosis injuries than myself. I mean, what do you like to see from clinicians post-operatively, and then also when they've seen you for an opinion and you've said, no, I don't think this is a surgical case, go back and see the physio?
Or not even post-operatively, even if it is one that is managed conservatively. Or not conservatively, non-operatively.
Non-operatively, yeah. So typically the ones where we're treating non-operatively, they've sort of got a single ligament injury, so it was from an ACL injury or